What should your benefit package look like in Medicaid? If you had the chance to simplify eligibility, to make this systems question a whole lot easier, what would you do? What does competition mean in an exchange? What does it mean to create an apples-to-apples comparison across health plan options? What do you want to do with your Medicaid health plans and MCOs? So many states operate an exchange essentially within Medicaid.
One of the things I've had to say to my staff is that we are in an era where uncertainty is the norm. And given the time frames that CMS is having to work in, given the time frames that we are having to work in with rules and regulations being developed almost as we're implementing things.
And we think about the range of roles that the exchange can play, from merely sort of a market organizer, i.e. like the stock exchange only for health insurance, moving all the way over to an entity through qualified health plan certification criteria, through selective contracting, through using whatever flexibility there might be with respect to the health plan rating.
And again, trying to staff up and identify the resources necessary to implement federal law in California. We don't yet know, for example, what our workforce needs are going to be in terms of answering questions, what kind of new appeals that we're going to get. We have still a lot of outstanding questions about the extent that California law harmonizes with federal law and the kind of additional federal or changes we need to make to state law in order to conform to federal law.
State has a good lesson, a best practice they can share. We look to our colleagues in Wisconsin, Minnesota, in best practices in a lot of their Medicaid programs. We look to the Northwest, Washington and Oregon on great coverage programs they've done with state funds. Obviously, Massachusetts is a program we're all looking to for their experience in operating an exchange. The S-CHIP programs. All the states have them. So much attention was put into outreach and how to bring people into those programs. Those are the kind of lessons that we need to build into our thinking about the exchange.
The other thing that has to be most important as we talk about the exchange is the horizontal integration, which is the idea of not only how are we pulling people into healthcare, both the exchange-related subsidy, the non-subsidy, the Medicaid, the CHIP, but also how do we use the exchange to engage our consumer base in those other programs that in many cases are very much underutilized. In my state, I'm also the SNAP director. So our food share program in Wisconsin, our SNAP program, tends to be a program that people have shied away from in the past a little bit. We want to use these same methods we're going to use for the exchange, for Medicaid, for CHIP, for the subsidy programs. We want to use those same techniques to determine eligibility, how much income people have, who's in their household, to see if they're eligible for food share. And we think that those same things are applicable to programs like WIC, to the energy assistance program, to housing assistance. We need to be looking at this as integrated human services and not just as a healthcare insurance exchange.
Our Medicaid program, we have had a history of really having more than just consumer involvement, but really almost like consumer governance, because we have such an active consumer advisory council. And the culture of our Medicaid program is that we want to know what's wrong from the consumer's point of view, because when we know what's wrong, we can then address it and make the program the best it can be.
Listening to Minnesota talk about how they are doing tiers in their patient-centered medical homes, and they're basing it on a patient screening tool rather than just using NCQA standards.
The idea of having one care coordination provider across all payers is an exciting idea that we're going to take back. There's several of us from Alabama and see what we can do with it at home.
I think it's really challenging for the feds because the timelines are obviously not what the feds would have desired. The major complaint that I hear from legislators and policy people is just the timing. Mm-hmm. A lot has been foisted upon CMS in terms of issuing regulations. I think timing is the issue. States are running on a treadmill to some extent, and we need assistance right away, yesterday really, to implement some of these decisions. And again, I think that will help to help legislators, policymakers understand what we are faced with so that we can proceed.
what we need right now is we really need some guidance. I'm not asking for regulations, not asking for a lot of specificity, but we need an idea of what the modified adjusted gross income is going to be. Is it going to be a number? Is it going to be a calculation? What part of the calculation is it going to be? Is it going to be about what household members are included? Is it going to be what income's included? Which particular part of this is about?
When we look at some of the all-payer initiatives that states are really trying to do with both private and public payers to change the delivery system, that it's going to be so important that Medicare be really at the table and not on the outside.
You know, I think the federal government can't determine the values that we want to promote in the system for each state, but I think they can help, the federal government can help to provide the resources to operationalize it.
To make sure that those who are eligible for a subsidy secure the subsidy and enroll in coverage, we need rules that are workable. We need those rules to be as simple as the law will allow. And we need CMS to guidance so that we can implement those systems and those rules in New York, and where CMS can't go as far as some states might like, that the states have the flexibility to go further.
Just getting us Medicare data and making it easy for us to get data for the duals.